The use of parenteral NSAIDs for acute pain management, either alone or in combination with opioids, is established and well documented. Ibuprofen is safe and effective analgesic that reduces opioid requirements and adverse events associated with other drugs of the same class. Our objectives for this presentation are straightforward. That is, to introduce Intrafen, the reformulated ibuprofen for parenteral use, and eventually that we gain confidence in its use to manage acute postoperative pain. Intrafen is a welcome addition to the limited number of available non-specific NSAIDs in our practice. This slide is a review of the prostanoid pathway. Arachidonic acid is cleaved from the cell membrane by phospholipase A2. Arachidonic acid is then converted to prostaglandin H2 by COX and to 5-HT by lipooxygenase. Prostaglandin H2, a precursor of all the prostaglandins, is further converted to different prostanoids by tissue-specific synthase. In the platelets, thromboxane is produced. As we all know, thromboxanes are responsible for platelet aggregation and thrombosis. In the endothelium, PGI2 or prostacyclin is generated, and this inhibits platelet aggregation and causes vasodilation. In the smooth muscle, prostaglandin E2, F2, and D2 are formed, which are all implicated in inflammation, fever, and pain. The anti-inflammatory effect of steroids results from the inhibition of phospholipase A2 and consequently decrease in the release of arachidonic acid from membrane phospholipids. On the other hand, aspirin and NSAIDs block the cyclooxygenase pathway, leading to a reduction of your prostaglandin H2. However, with the inhibition of COX, the released arachidonic acids are converted to leukotrienes, and this can explain why we sometimes encounter bronchoconstriction in susceptible individuals given NSAIDs. There are two types of clinically significant COX enzymes, COX-1 and COX-2. COX-1 enzyme is constitutively or physiologically expressed, whereas COX-2 is inducible, upregulated with a little constitutive function. Both enzymes produce prostaglandins that promote inflammation, pain, and fever. However, only COX-1 produces prostaglandins that activate platelets and protect the stomach and intestinal lining. And so, if we administer non-selective COX inhibitors, both isoenzymes are blocked. This inhibition leads to not only beneficial therapeutic effects, namely reduction of pain and inflammation, but also a number of detrimental effects, such as risk for bleeding, gastropathy, and nephropathy. Now, on the other hand, when COX-2 is inhibited selectively, it leaves COX-1 unopposed, as well as contributes to prothrombotic events by reduction in prostacyclin expression, therefore tipping the balance between prostacyclin and thromboxane in favor of thrombotic occurrence. This may explain the increased risk for cardiovascular events such as myocardial infarction and stroke. This slide summarizes NSAID side effects. In the GIT, non-selective COX inhibition will block the protective effect of COX-1, increasing the risk for peptic ulceration. COX-2 inhibitors will spare COX-1, therefore their safety profile for the GIT is better. On the kidneys, both non-selective and selective NSAIDs can have negative effects, especially in high doses and prolonged use. On the vascular endothelium, selective COX-2 inhibitors can reduce prostacyclin expression, favoring thrombotic events. Thromboxane activity, being a COX-1 function, is not suppressed, again tipping the balance in favor of thrombosis. In the platelets, non-selective NSAIDs will reduce thromboxane expression from COX-1 enzymes, favoring antithrombosis. Interestingly, low-dose aspirin irreversibly inhibits platelet COX-1, affording protection for the cardiovascular system. Several studies have shown that there may be a window of safety in the use of these drugs, and this lie on COX selectivity. Here is a classification of NSAIDs based on their COX selectivity. Group 1 are NSAIDs that inhibit COX-1 and COX-2 completely with less than 5-fold selectivity on COX-2. and this includes ibuprofen. Group 2 are NSAIDs that inhibit COX-2 with a 5 to 50-fold selectivity like celecoxib. Group 3 are those NSAIDs that inhibit COX-2 preferentially with greater than 50-fold selectivity like rofecoxib, which was found to be associated with stroke and myocardial infarction. Lastly, Group 4 are those that are weak inhibitors of both isoforms. It would appear that the selectivity is closely related to the probability of unwanted adverse effects. This chart shows the comparison of COX-1 and COX-2 activity of different NSAIDs and among the NSAIDs. First, oral ibuprofen 2,400 mg per day demonstrated inhibition of COX-1 activity by 88.7% and COX-2 activity by 71.4% in healthy volunteer study. Secondly, ibuprofen is one of the drugs with lowest COX-1 inhibition, where it inhibits COX-1 2.5 times more than COX-2. Thirdly, ketorolac inhibits COX-1 over 300 times more than COX-2 in humans. Fourth, although these NSAIDs are called non-selective, their inhibitory effect is mostly seen in COX-1 with lesser degree of COX-2 inhibition. Studies prove that adverse event profile of ibuprofen is better since COX-1 to COX-2 ratio is lower. So to answer the question, which NSAID is safer, it would seem that adverse events is affected by the duration of treatment, pre-existing conditions, and drug interactions. Always use the lowest effective dose and the shortest period of time to address pain to reduce or avoid its detrimental effect on physiology. Limit the use of non-specific NSAIDs for 3 to 5 days. If there are already pre-existing renal dysfunction or significant GI problems, make sure that the benefit outweighs the risk. And lastly, consider its interaction with the other medications the patient may be taking. Despite the potential harm that may be caused by NSAID use, these drugs are still recommended in the management of post-operative pain by reputable institutions like the WHO Analgesic Ladder of Therapy for one. NSAID use is also included in both the American Pain Society and American Society of Anesthesiologists as part of multimodal analgesia for management of post-operative pain. The ASA included in the acute pain management guideline that patients should receive round-the-clock regimen of NSAIDs, COXIBs, or paracetamol unless contraindicated. No drug can challenge the anti-inflammatory effect of NSAIDs other than probably steroids, which admittedly have more side effects. Briefly, I will go through the pharmacology of ibuprofen. Ibuprofen's discovery was in 1950s and 1960s, but it was only patented in 1961. It was marketed as a prescription drug in UK in 1966, followed by the US in 1974. In June 2009, the first IV ibuprofen was approved for pain in the US. In 2015, Intrafen was launched in Turkey. In 2018, Delex Pharma launched Intrafen in the Philippines. Intrafen is approved in the Philippines for the management of mild to moderate pain as a sole agent, for moderate to severe pain as an adjunct to opioid analgesics, and for the reduction of fever. Ibuprofen is a propionic acid derivative that has analgesic, antipyretic, and anti-inflammatory properties. It is highly protein-bound with a terminal half-life of 2 hours consistent across all dosing range. Intrafen's antipyretic effects are delayed despite declining plasma ibuprofen concentrations. Ibuprofen acts on the cyclooxygenase pathway and inhibits the production of prostaglandins to prevent sensitization of pain receptors at the site of injury. Centrally, it has an effect to the spinal cord by blunting central sensitization. This slide shows the pharmacokinetic values for a single dose of 800 milligrams or 400 milligrams IV ibuprofen infused over 30 or 60 minutes compared with a single oral dose. Data are presented as mean, SD, or mean, and were compiled from several different studies for comparison. The data reveal that Cmax decreases considerably as the length of the infusion increases, and that an oral dose is not able to achieve the Cmax level of any of the intravenous doses. So, the longer you infuse ibuprofen, the lower the Cmax level is. It is more ideal to infuse Intrafen over 30 minutes for both 400 milligrams and 800 milligrams. This is a summary of pharmacodynamic studies. It shows that the use of IV ibuprofen 400 milligrams or 800 milligrams significantly reduced post-operative use of morphine and pain with movement following surgery. This multi-center randomized double-blind parallel and placebo-controlled study done in 2010 demonstrated that IV ibuprofen appears to be safe and effective for the short-term treatment of fever in hospitalized patients unable to tolerate oral medications. Results show that all IV ibuprofen dose levels resulted in a statistically significant reduction in the number of patients with temperature less than 38.3 degrees centigrade after 4 hours. All doses of IV ibuprofen tested reduced fever at 4 hours and throughout the first 24 hours of dosing. The 400 milligram dose was effective in lowering temperature to normal and maintaining this over the first 24 hours of dosing. IV ibuprofen was effective in reducing fevers in critically ill and non-critically ill groups. Following 24 hours of administration of IV ibuprofen, no clinically significant differences in any safety parameter including renal function or bleeding occurred through the 28-day follow-up period. Here is another summary of pharmacodynamic studies of IV ibuprofen for the reduction of fever, where all temperatures significantly decreased. Taken together, these studies demonstrate the antipyretic efficacy of a 30-minute infusion of IV ibuprofen in adult patients with a strong safety profile. This is a pooled analysis in treatment emergent adverse events comparing ibuprofen 400 milligrams, 800 milligrams, and placebo. Overall, the most common treatment emergent adverse events occurring in at least 10% of patients during intravenous ibuprofen treatment in analgesia clinical trials were nausea, flatulence, hemorrhage, vomiting, and headache, with dizziness and urinary retention occurring in at least 5% of patients. The recommended analgesic dose is 400 milligrams to 800 milligrams IV infusion every 6 hours with a maximum daily dose of 3,200 milligrams. For fever, it is recommended to give 400 milligrams IV infusion every 4 to 6 hours or 100 milligrams to 200 milligrams every 4 hours. The lowest effective dose should be used for the shortest duration consistent with individual patient treatment goals. And just for precaution, the patient must be well hydrated prior to IV ibuprofen administration to reduce the risk of renal adverse events. Ibuprofen is soluble in agents such as acetone and ethanol, but only slightly soluble in water. To prevent serious phlebitis during administration, the final concentration during admixture must be resulting in a final solution of no less than 100 ml for the 400 milligrams or 200 ml for 800 milligrams. NSAIDs in general may increase the risk of serious cardiovascular thrombotic events, myocardial infarction, and stroke, which can be fatal. This risk may increase with duration of use. Patients with cardiovascular disease or risk factors for cardiovascular disease may be at greater risk. Intrafen is contraindicated for the treatment of perioperative pain in the setting of coronary artery bypass graft surgery. NSAIDs increase the risk of serious GI adverse events, including bleeding, ulceration, and perforation of the stomach or intestines, which can be fatal. And these events can occur at any time during use and without warning symptoms. Elderly patients are at greater risk for serious GI events. Pregnancy and lactation, Category C prior to 30 weeks gestation, and Category D starting 30 weeks gestation. The most common side effects reported were nausea, flatulence, vomiting, and headache. Ibuprofen may interact with other antiplatelet drugs and SSRIs. Both may increase incidence of GI bleeding. In addition, the antidepressant effects of SSRI can be attenuated by anti-inflammatory drugs in mice and humans. In summary, Intrafen presents an effective therapy for the treatment of pain and fever with a strong safety profile. It is an effective analgesic that is safe and well tolerated when administered as an 800 mg dose every 6 hours. Ibuprofen has been rated as the safest conventional NSAID by Spontaneous Adverse Drug Reaction Reporting Systems in the UK. In my practice, I use it as sole analgesic for minor surgeries. For major surgical procedures, I give Intrafen 800 mg every 6 hours in combination with other pain regimen. I skip it in patients given steroids like in neurosurgery. And I don't give paracetamol anymore when I use Intrafen. The next few slides present commonly asked questions. The first question is, can Intrafen be used in pediatrics? Based on clinical studies, ibuprofen is the most widely used NSAID for the treatment of inflammation, mild to moderate pain, and fever in children, and is the only NSAID approved for use in children aged 3 months and older. US FDA has approved IV ibuprofen to be administered to pediatric patients 12 to 17 years of age with a dose of 400 mg IV every 4 to 6 hours over 10 minutes with a maximum daily dose of 2,400 mg. For ages 6 months to 12 years, the dose is 10 mg per kilo IV up to a maximum single dose of 400 mg every 4 to 6 hours over 10 minutes. Maximum daily dose is 40 mg per kilo or 2,400 mg, whichever is less. Although oral ibuprofen is commonly prescribed in pediatrics by Filipino pediatricians, Delex Pharma prioritized approval of Intrafen for adult use. They will be seeking approval of Intrafen for use in pediatrics in the near future. The next question is, can it be given to patients with azotemia? The answer is no. It is unsafe and will aggravate renal dysfunction. On the other hand, consider the risk-benefit ratio in patients with ESRD, whose kidneys are already non-functional. There may not be any remaining function to affect. As a review, renal prostaglandins function primarily as vasodilators in the kidneys. In healthy individuals, the impact of prostaglandins on renal perfusion is relatively limited. However, in a setting of prolonged renal vasoconstriction that develops during settings of advanced age, heart failure, and kidney failure, prostaglandin synthesis is upregulated. Under these conditions, when kidney function is compromised, the production of prostaglandins serve an important role to preserve renal blood flow and protect GFR by decreasing preglomerular arterial resistance. Even episodic use of NSAIDs can decrease blood flow through the glomerulus and increase the risk of acute kidney injury. Another question is, should prophylactic use of PPI or H2 blockers be given if NSAID is utilized? The answer is based on the pathology of NSAID-induced gastropathy. In the stomach, coxon-mediated production of prostaglandins PGE2 and PGI2 play an important role in regulating the production of bicarbonate and mucus, as well as regulating normal blood flow. These are the physiologic mechanisms compromised by NSAID use. Hence, blocking COX-1-mediated production of prostaglandins in the stomach by aspirin and other non-selective NSAIDs is expected to increase the incidence of peptic ulcers. H2 antagonists are poor at preventing gastric ulcer development or recurrence. These problems can be overcome by the use of more potent acid suppression from PPIs like omeprazole or pantoprazole and the like. But the drug of choice for treatment of ulcers induced by NSAIDs is misoprostol. It reduces incidence of NSAID-induced ulcers to less than 3% and the incidence of ulcer complications by 50%. Its limitation is associated with its side effects and the need for frequent dosing. Is Intrafen safe for use in the elderly? As previously discussed, renal changes associated with advanced age make this population susceptible to a decreased renal blood flow through the glomerulus and increased risk for AKI. I give Intrafen because of its superior anti-inflammatory effect. If needed to enhance patient recovery, I give it for a short period of time only. It is also recommended that the hydration status be optimized prior to treatment. Another common question is, when should the 400 mg preparation be used? The 400 mg stock dose is adequate for pediatric usage as well as for antipyretic dosing. Can it be used in combination with paracetamol? It is my personal opinion that Intrafen already encompasses the mechanistic action of paracetamol. A proposed mechanism of action of paracetamol is centered on its inhibition of prostaglandin oxygenase, reducing conversion of the intermediary prostaglandin G2 to prostaglandin H2, which is the precursor of the different clinically significant prostaglandins. Can it be used in patients who had significant bleeding intraoperatively? The concern in these patients is the presence of a setting for AKI. If the blood loss is adequately replaced and the source of bleeding is identified and controlled, Intrafen can be given for acute pain control. Can you give it to lactating mothers after cesarean section? All of the studies and articles I reviewed point to the fact that the amount of ibuprofen in breast milk is so minute that it is clinically insignificant to cause problems in the infant when the recommended dose of ibuprofen is given to the mothers. Is it safe to give in patients with significant cardiovascular disease? As previously discussed, a greater inhibition of COX-2 versus COX-1 can tip the balance in favor of thromboxane formation, vasoconstriction, and platelet clumping, which are more likely to occur. And there is an increased risk for cardiovascular events such as myocardial infarction and stroke. The FDA has issued this black box warning stating that the risk for heart attack and stroke is increased with NSAID use and that its occurrence may manifest as early as the first week of use. It is also stated that the risk appears to be greater in higher doses. So, to answer the question, yes, it is probably safe to give Intrafen to control acute postoperative pain within the recommended dose for a short period of time, usually 7 days or shorter. The American Heart Association currently recommends that when NSAID therapy is needed, NSAIDs should be used at their lowest effective dose. Prudence dictates that use should be on a case-to-case basis.